Hello my friends, welcome to my YouTube channel. My name is Dr. Saeed Kazmi, and in today's video I'm going to talk about hematuria in children. So let's start with the definition. Hematuria simply means blood in the urine. Now around 0.5 to 2% of the children usually do present to the clinics with this complaint. So either the parents, they tell us that they have noticed that the child is passing red color urine, or sometimes they would say that the child is passing very dark colored, tea colored or cola colored urine, or sometimes they would say that they have found red spots or red sort of a thing in the child's diaper, and they think it's blood in child's urine. So that's how most of the times the problem of hematuria in children presents to us in the clinics. Now, as I told you earlier, that by definition it means blood in the urine. Now it's usually of two types, what we call as gross as macroscopic hematuria, and the other one is microscopic hematuria. Now please keep it in mind that it's not necessarily that a red colored urine would mean that there is blood in the urine. We have to check it by chemical methods. So let's start with the types. So there are two types of hematuria: gross hematuria and microscopic hematuria. Gross hematuria means when you can see that the urine is red color. In other words, as people say, that they can see blood in the urine. Microscopic hematuria is when you cannot see blood or red colored urine, but when you test it chemically, you find that there is blood in the urine. And by definition, microscopic hematuria is when you find more than 5 red blood cells per a single high power field under the microscope. Though nevertheless there are some chemical methods as well which can detect the presence of red blood cells in the urine. As I told you earlier, that around 0.5 to 2% of the children can present with the complaint of hematuria. Now let's talk about the pathophysiology or the pathogenesis of hematuria in children. In other words, we will try to find out what are the reasons that can cause presence of blood in a child's urine. Now let's talk through what we call as multi-system disorders. Now multi-system diseases or disorders are usually autoimmune disorders in which multiple organs are involved, and kidneys are one of the organs that can be involved in these multiple system diseases. The first one is what we call as lupus. Systemic lupus erythematosus is a multi-system autoimmune inflammatory disease in which the kidneys can be involved, and if the kidneys are involved, the child can present with blood in their urine. More common than the SLE is what we call as HSP, which stands for Hematuria spondylosa purpura, which is an IgA vasculitis of the medium-sized blood vessels. And one of the common presentations of HSP is hematuria, and with hematuria the child can present with a palpable painful rash around the buttocks or on the lower extremities. Nevertheless, it can present even on the upper extremities, but most of the time the most common presentation is abdominal pain, hematuria, and a presence of a palpable non-blanching rash on the lower extremities. Then we have got some other rare multi-system disorders like Goodpasture syndrome and vaginous granulomatosis, which can involve the lungs and which can involve the kidney. So a child can present with complaint what we call as hemoptysis, and at the same time they can present with hematuria as well. But these are multi-system disorders and they're a bit rare as compared to HSP. HUS stands for hemolytic uremic syndrome. It's caused by Shigella campylobacter, but nevertheless it can present with hemolysis, it can present with a rising urea levels, and it can present with hematuria. Sickle cell, mostly in African population, can present with hematuria, blood in the urine, and rarely HIV nephropathy, in which if the kidneys are involved, then the child can present with blood in the urine. Now also keep in mind that red colored urine does not mean that every time if a child comes with a history of a red colored urine, it means that it would be blood. Please keep it in mind that certain types of things can give a red color to the urine, and well, they think it is blood, but in fact it is not, and we can test it with chemical methods. No, remember, sometimes in severe injury, if there is rhabdomyolysis in which the muscle breakdown is there, myoglobin comes and is excreted in the urine, which can also give a red color to the urine, and it can be mistaken for hematuria. In fact, it is myoglobinuria. Hemoglobinuria, which is basically the excretion of hemoglobin in the urine, and can be caused by different hemolytic disorders that can also present with the red colored urine. Certain types of drugs like pyridium or rifampicin can give a red color to the urine. Certain dyes like aniline dyes, which are used in candles, their exposure can also lead to a red colored urine, which might mix like hematuria. Metabolites like certain diseases in which there is a breakdown of certain metabolites like porphyria, like the disorders of bilirubin breakdown, or tyrosinemia can also present with red colored urine. Certain foods, like if a child has consumed a lot of beets or has consumed a lot of blackberries, can also give a red tinge to the urine and can be mistaken for hematuria. Last but not the least, sometimes, and especially this happens in neonates, parents are very much concerned when they come to us and they say they think that there is blood in a child's diaper, and when we open up, there is usually a pinkish red color tinge inside the diaper. Sometimes it leads to a lot of investigation as well, but usually nothing is found. The child is absolutely normal. So urate crystal excretion can give a red color to the urine, which is sometimes mistaken as hematuria, and it's quite a common complaint in neonates. Now, in your clinics, when you come across a child who presents with a history of hematuria, it's important to ask certain questions, because the history and physical examination can lead to the possible causes. It's very important that in any child you must ask if there has been a history of recent sore throat or skin infection, because certain nephrogenic strains of streptococcal bacteria can cause what we call as post-streptococcal glomerulonephritis, which is inflammation of the kidneys, and usually presents with the high blood pressure and hematuria. You should also ask about some associated fever, pain in the flanks or pain in the suprapubic region, or a history of dysuria, or in other words, pain while passing urine, because if this symptomatology is present, it usually goes more in favor of a urinary tract infection, which could be either a lower urinary tract infection like cystitis or urethritis, or it could be an upper urinary tract infection like pyelonephritis. You should also check their blood pressure, because if the blood pressure is raised, it simply means that there is renal involvement or renal parenchymal involvement. Most of the time this usually happens in glomerulonephritis. You have to also ask about a family history of renal disorders, and especially if there's a history of renal disorders, whether it is associated with deafness or not, because Alport syndrome can have an autosomal dominant pattern in the families, and it can present with history of renal involvement, hematuria, and deafness in successive generations. You should also ask about history of associated medical problems, like if somebody is already a diagnosed case of SLE, then obviously if they present with hematuria, you can attribute that hematuria to SLE. If they got a history of sickle cell disease, you can think that the hematuria is being caused by sickle cell crisis. You should also take a history of purpuric rash and abdominal pain, and especially look for a rash on the lower extremities, because if a palpable non-blanching rash is present, it goes in favor of Henoch's colony purpura, or HSP as we call it. And always ask about history of trauma, because certain children who actually fall from a height or are involved in let's say road traffic accident or any other trauma which causes blunt trauma to the back, they can present with hematuria because of the blunt injury to the kidneys. Then, apart from the problems with the renal parenchyma, problems with the renal tubules and the ductal system inside the kidneys can also give rise to hematuria. Some of the tubular diseases which can cause hematuria are pyelonephritis, which is basically an urinary tract infection of the upper renal tract. Interstitial nephritis can also give rise to hematuria. Acute tubular necrosis, in which due to an infection or due to hypoxic injury, the tubules can get necrosed and can present with hematuria along with acute renal failure, and sometimes papillary necrosis can also present with hematuria. Vascular disorders can also cause hematuria. Certain arterial or venous disorders in which there is clot formation either in the arteries or in the venous, like renal vein thrombosis or renal artery thrombosis, can give rise to hematuria. So some of the thrombophilic disorders that can give rise to hematuria as a complication, or certain conditions in which there is dehydration and tendency to for formation of clots, like in nephrotic syndrome. There can be formation of clots in the renal venous system. We call it renal venous thrombosis, and that can present as hematuria. Certain anatomical problems of the vasculature, especially if there is aneurysm in the branches of the renal artery, that can give rise to hematuria. And hemangiomas, especially if there is a history of multiple organ hemangiomas. These hemangiomas, which are basically an abnormal growth of the capillaries, they've got a tendency to bleed, and if they bleed, the child can present with gross or microscopic hematuria depending on the size of the hemangioma. Also, the anatomical problems within the renal tract can also give rise to the complaint of hematuria. Hydronephrosis, which is the gross dilatation of the kidneys, that can give rise to hematuria. Polycystic kidney disease, either the autosomal recessive or the autosomal dominant. Please keep it in mind, autosomal recessive is more common in children, autosomal dominant is more common in adult. Irrespective whether it's the autosomal recessive variety or the dominant variety, can present with gross or microscopic hematuria along with hypertension. Multicystic dysplasia, which are dysplastic kidneys and can happen as part of various syndromes, or can even happen in isolation, that can give rise to hematuria. Similarly, tumors like Wilms tumors in the pediatric age group can give rise to microscopic or gross hematuria. And then renal trauma, as I told you, either direct or indirect trauma can result in hematuria. Also keep it in mind that the problems in ureter, bladder or in urethra can also cause hematuria. Some of the problems like ureteric stones or stones in the bladder, or sometimes even if they are lodged in the urethra, can lead to hematuria. Similarly, infection in the bladder, which is called as cystitis, or infection in the urethra, which is known as urethritis, which can occur sometimes as a part of STD, that is sexually transmitted diseases as well, can give rise to hematuria, especially in adolescent boys or girls. Trauma in any form to the ureters or to the bladder or to the urethra can give rise to hematuria. Last but not the least, bladder tumor can also lead to hematuria. Also keep it in mind that some of the isolated renal diseases can also give rise to hematuria. I would like to talk about IgA nephropathy. IgA nephropathy usually leads to gross hematuria, painless hematuria, and usually there is a history of an upper respiratory tract infection, and after 2 to 3 days the child presents with gross painless hematuria, and that is caused by IgA nephropathy. Please keep it in mind that sometimes there is a confusion whether the hematuria is because of post-streptococcal glomerulonephritis or IgA nephropathy. Usually post-streptococcal glomerulonephritis usually happens 10 to 14 days after a streptococcal sore throat or a streptococcal skin infection, while IgA nephropathy usually happens 2 to 3 days after an upper respiratory tract infection. Alport syndrome, which is basically hereditary disease, X-linked, and leads to deafness with renal involvement, can present with hematuria. Focal segmental glomerulosclerosis, which is basically sclerosis of the different segments within the kidneys, that can also lead to hematuria. Rapidly progressive glomerulonephritis, which can happen in so many diseases, in which what happens is that there is very rapid sclerosis of the glomerular apparatus, and it spreads very quickly within involving all the glomeruli, and that can lead to hematuria. Membranous nephropathy can also lead to hematuria, and sometimes benign familial hematuria, which is also known as thin membrane disease, especially if there is a family history of hematuria again and again, and there is no history of deafness, then you can think of benign familial hematuria. Now, as far as diagnosis of hematuria is concerned, as I told you that most of the time it's the parents who bring their child and they say that they have noticed blood in the child's urine, and they might bring a sample with them and tell you that, see, this is what we have found, or they might tell you that there was red spot inside the diaper, and they may bring those diapers. Now, how do we know it is actually blood? We have to take a fresh sample of urine, and we have to check it either with urinalysis or with chemical methods to see whether there is actually blood within that urine sample or not. So there normally we use the urine dip stick methods, in which chemically it can see whether it can detect if there is blood in the urine sample or not. But if it is detected by chemical method, it is very important to take a sample of the same urine and check it under the microscope. We call it urinalysis, and the person who is doing that urinalysis, he has to look for the presence of red blood cells in that urine sample, because if there are no RBCs, then there is something else which can give rise to red color, as it could be myoglobin, it could be hemoglobin, it could be something else. Now, at the same time, the chemical methods, they also detect for the presence of protein, and it's very important that while you're doing a urine dipstick, it's not the blood alone that can give you the what you call as a clue to the diagnosis. There are presence or absence of other things as well that can give a clue what could be the diagnosis. Like, for example, if somebody has got presence of blood in the urine sample, and at the same time the nitrates are positive and the white blood cells are present, then obviously that goes more in favor of a urinary tract infection. But let's say if there is presence of protein, then we have to see whether it's more of the red blood cells in the or blood in the urine, or it's more of the proteins. Because if it is more of the proteins and less of the blood, then it goes more in favor of what we call as nephrotic syndrome. But if there is more of blood and less of protein, then it goes more in favor of nephritic syndrome, which are the different type of glomerulonephritis. Or you can have a mixed picture, we call the mixed nephritic picture, in which you can get blood as well as a lot of protein. So the balance between the protein and the blood levels can give you whether it's going more in the favor of nephrotic or more in the favor of nephritic syndrome, simply by the presence of the blood and protein in a urine sample. And also keep it in mind that if there are symptoms and signs of UTI, then presence of nitrites in the urine sample is very much specific for the presence of a urinary tract infection. While the positivity of other markers like leukocyte esterase, white blood cell, is not that much specific, though most of the time it means that there might be a UTI, but it can also happen in many other problems as well, not necessarily infections. Urine electrolyte can also help, especially if you take the ratio of the urinary calcium to creatinine. A high ratio could mean that there might be stones anywhere in the renal tract, which we call as nephrolithiasis. And the blood chemistry and blood tests can also be very helpful in finding out the different causes as well as the associated problems in case of hematuria in children. The chemistry 7, which is known as a basic metabolic panel, which looks for your electrolytes, your blood urea nitrogen, the blood glucose level and creatinine levels, as well as the bicarbonate levels and chloride levels, can give you an idea whether there is any what you call associated features of acute or chronic renal failure or not. Because the blood urea nitrogen is high, the creatinine is high, you can imagine that there might be some form of acute kidney injury as well. Similarly, the white blood cell counts along with the platelets, hemoglobin and hematocrit can also help you to see whether there is any associated infection of the kidneys or not. And at the same time, if the patient is exhibiting features of multi-system disorder, then the what you call the measurement of complement levels can give us an idea. Usually in multi-system disorders like lupus or even in post-streptococcal glomerulonephritis, you will usually see that the C3 and the C4 complement levels are quite low in the blood. Then once we are done with the urine studies, we are done with the blood studies, it's also very important that sometimes we use imaging studies as an associated diagnostic modality to know the extent of involvement of the other organs of the excretory system as well. And most of the time, the first imaging modality that we use is renal ultrasound. Like for example, lateral ultrasound after a UTI can be used to detect the presence of renal scarring. It can also detect if there are any renal stone. It can detect if there is gross dilatation of the kidneys in the presence of hydronephrosis, etc., etc. CT is not that much commonly used because of the associated dangers of radiation. Nevertheless, sometimes we can use a CT if needed. Avoiding cystourethrogram is usually useful for hydronephrosis because it can actually delineate the whole urinary tract, and you can see the level of dilatation up to which level it extends. And last but not the least, cystoscopy is basically imaging modality in which you pass a cystoscope in the bladder and you look at the inside of the bladder to see if there is any growth, if there is any other thing, abnormality in the urinary bladder which might be responsible for hematuria. And sometimes we can use what we call as a combination of different imaging techniques. It also includes some of the advanced imaging techniques like the MAG3 scanning, blah blah, but I don't want to go into the detail of that. I would discuss it at some other time, but nevertheless these can be used in order to find the causes for hematuria. Now, as far as the treatment is concerned, please keep it in mind that there is no direct method or drug which would control the hematuria. It's always looking at the cause. So if the cause is, let's say, glomerulonephritis, then obviously you have to treat it with steroids, or sometimes in extensive disease you might have to use immunosuppressant drugs as well. So you treat the root cause that would treat the hematuria. So that is very important. Like for example, if it is being caused by stones, then you have to remove that stones or give some treatment so the stones can pass out. And obviously once they have passed out and the injury is healed, there will be no more hematuria. So please keep it in mind, the treatment of hematuria, if you are asked, is that the treatment of the underlying cause is the treatment of hematuria. So I hope you have understood what is hematuria in children, what are the common causes, and what are the common diagnostic modalities that we use in order to work up for the complaint of hematuria in children. I hope you have liked my video, and if you have liked, subscribe would be fantastic. It helps. And also share my videos with your friends, and do comment if you've got or if you don't understand anything, or if you need to ask a question, please put it down in the comment section below, and usually I get back within a couple of hours to answer your questions, queries. Have a good day. Bye bye.